Hi, everybody. We're going to talk today about the COVID-19 vaccine and talk about some truthful information and some misinformation that's out there and disinformation about what those things are. So today we'll talk about an introduction and just go over the situation a bit. We'll talk about risk, what that is, and compare some different risks. We'll talk about what information is, what misinformation is, and what disinformation is. And then we'll go over some common COVID-19 vaccine questions and answers. So why am I here talking to you? I just wanted to give you a little background about who I am and why I'm here and why my opinion might matter to you. So my name is Jennifer Morse. I'm a medical doctor, so I'm Dr. Morse. I've been a doctor for 20 years now. I specialize and I'm board certified in family medicine, and I also have a master's degree in public health. So I have lived in Clare County for my entire life, except for the 11 years that I was gone getting my medical education and training. I practiced family medicine in Clare for just over a decade. And during that time in family medicine, you take care of all ages. I actually delivered babies for a short time. And so with that population of patients, I gave a lot of vaccines during my career in practice. And since then, I have worked as the medical director for 3 local health departments, which cover 19 counties for the last 5.5 years. And this image here on the right shows those 3 health departments. This is District Health Department number 10, Central Michigan District Health Department, and Mid-Michigan District Health Department. And I listed those counties here. So I'm really proud to cover such a large, diverse area of Michigan. And with that job, we give a lot of vaccines, and I need to know quite a bit about vaccines. I also work for the peer education program, which is run through Michigan State University and the Michigan Department of Health and Human Services. And through that, I provide education about vaccines to other healthcare providers. My family and I are all fully vaccinated, and all of my family that's old enough at this point has gotten the COVID-19 vaccine. And I'm very excited for it to be approved for children 12 and up. And as soon as that is, then my children will get vaccinated as well. So just to acknowledge that this past 1.5 years has been really difficult. We knew that, at some point we'd have another pandemic. We never knew it would be like this. This has been just really, really difficult. And for those who are not in healthcare, who are not in public health, you just never know what is coming and what it could be like. So there's still so much uncertainty of what's going to happen, how this is going to end, so many questions, so many unanswered questions. And it's so hard to be able to hear people like us say to you, we just don't know yet. We felt like we haven't had much control over our own personal lives, over our situations, over our future. And that's really, really difficult. So it's okay to have concerns. It's okay to question things. It's okay to want more information. It's normal, and you should. It's your body, it's your health, it's your family. So we do have some reasons now to feel hopeful, though. We see some light at the end of the tunnel. That tunnel may have bends and curves that take that light out of our vision for a moment, but we do have some light at the end of the tunnel. There are some promising new treatments that are being used for people with COVID-19 infection. And we do have, right now we have 3 effective vaccines that are widely available. So we have hope at ending this pandemic. You have empowerment right now to take your own health and safety into your own hands, and to also help protect your friends, your family, and your community by getting vaccinated, by continuing to wear your mask in public, and to avoid gathering with large groups of people, especially indoors, until this pandemic is under better control. So when is this ever going to end? We need enough people to be immunized for COVID-19 or to be immune to COVID-19, that if someone gets infected, it's not going to easily spread to other people because of that immunity in our community. So in other words, we have to break the chain of transmission. This is called community immunity. We sometimes call it herd immunity. And there's 2 ways that we can get people immune. One is through natural infection. So basically you get sick with COVID and your body mounts a response to that. We don't really know for sure how long that immunity lasts because this is a new infection. It seems to be at least 3 months in the majority of people, and it's likely much longer. Really, as we followed people that have been infected in the beginning of this pandemic, most of those people are still immune. So it seems to be 8, 9 months, 12 months or more. But getting immune that way comes with the risks from the illness of COVID-19. And I'm going to go over that more in depth in a bit. The other way to get immune is through vaccine immunity, which occurs after you get vaccinated. Usually vaccines do give you longer lasting immunity because it's very specific. When you're ill, the inflammatory response that happens when you're sick can actually blunt some of your immune response because you're just so sick. Plus, there's just a lot of risk that comes along with getting sick. And again, we'll talk about that more in a minute. Plus, with vaccines, most of them have boosters. And if we do notice that immunity is dropping with time, there can be boosters given. So again, usually with vaccines, immunity is more robust, it lasts longer. You have immune cells that are called memory cells that are ready to get to work and go to action if you're re-exposed in the future. So since COVID-19 is a new illness, we really don't know for sure how much of our community needs to be immune to stop this pandemic. You may hear oftentimes that it's 70% or more. We just don't know for sure though. It's something we're going to have to understand better as we go. Based on what we know from other diseases, other infectious diseases, it is likely somewhere between 70 to 90%, or about 7 to 9% of people in our community will need to be immune to COVID-19 for this pandemic to stop. Since people come in and out of our area all the time, whether it's from other counties, states, countries, really the entire population in our country, in our world, are going to need to have that 70 to 90% immunity in order for the pandemic to stop. Likely, COVID-19 is not going to go away completely. Just like with flu and other infectious diseases, the only one we've ever eradicated is smallpox. So it'll be around. It's just a matter of getting enough of us immune that it's manageable and it's not causing huge outbreaks and huge hospitalizations and deaths. So this video just shows how an outbreak can get under control with vaccination. So I just want to see if I can pause this. Oops, I'm sorry. I don't think I can pause this, but the blue dots are people that are unvaccinated. The yellow dots are people that are vaccinated. And as you can see, when you have more and more people vaccinated, it is harder for that infection to spread because there's fewer people that come in contact with each other that can become infected. So this just gives a good illustration as we get more and more percent people immune, that virus can't spread as quickly or as easily. So usually with most illnesses, we do need towards the 90 to 95 percentile to really stop infections. We can at least slow it down significantly once we get past 70%. So that's just an illustration of how community immunity or herd immunity works. So how close are we right now? This is pretty busy. I know that this is a quite busy slide, but it just presents some data that really is explaining that at best right now, our state is just over 50% immune to COVID-19. So we need at least 20% more of our population, or around 2 million more Michiganders, to become immune if we're shooting for that 70% target. The way I figured this out, the CDC is randomly testing blood samples. So if people get blood work done, they're getting them to consent to have their blood samples tested for antibodies to COVID. And as of February, the age-adjusted positivity for antibodies that could not be due to vaccination was 18.9%. And as of April 23rd, the age-adjusted vaccination rate, fully vaccinated rate, was 35.5%. So I added those two together essentially. And this is all, just giving us a ballpark. So why I put one of the questions here ahead of time from our question and answer section, just to address this right away. Wouldn't it be better to just let the virus spread through our community and let us get herd immunity through natural infection? So again, at best, about half of our population is already immune. At best, about 46% or around 4.6 million people in Michigan are not immune. And if 20% of those would need to get immune to give us that 70% immunity, and we let all 2 million or 20% of those people get infected, on average, 1 to 2% people who get infected die. And so that would be another 20 to 40,000 people who could die from COVID if we allowed natural immunity to give us our herd immunity or our community immunity. So far, as of April 28th, we've had just over 17,000 people die in Michigan. So that would double, if not triple, how many people we've already had die in Michigan if we let natural immunity take us to that herd immunity level. So that's our hope. And that's why we've tried to protect everybody from infection, is that we want people to avoid those risks of infection and get immunity through vaccination, because it's just much, much safer. So what are the risks of illness from COVID compared to the risks to vaccine? Some of these slides are quite busy, so if you need to pause it so you can read them, go ahead. So with vaccination, we know that our body has to fight the protein in the vaccine so our immune system can develop antibodies. And that gives us some symptoms like an infection for a couple of days. Not in everybody, but in some people. So you may have pain where you got the shot. You might feel tired. You might have muscle pain, headache, chills, fever for a few days. That is very common. And I put the percentages for each vaccine based on the latest evidence on the slide here. With COVID infection, about 1 to 2 out of every 6 people who get infected may never have any symptoms at all. However, they can still spread it to other people. So with the vaccine, again, you may not have any side effects at all, but you're definitely not going to spread infection to other people. With infection, about 4 or 5 out of 6 people are going to have symptoms. And the symptoms are somewhat similar to what the vaccine would be, but they may last much longer. And I'll talk about that a little bit more in a minute. But people will have cough, muscle pain, fever, headache, shortness of breath, sore throat, diarrhea, nausea, vomiting. So a little bit longer list than with the vaccine, but again, people get sick. So that is the risk. So of that 4 to 5 out of 6 people who do get symptoms, about 80% of them, or about 4 out of 5 of them, are mild enough to stay home and get better. About 1 out of 5 of them are going to need to go to the hospital. And of those that go to the hospital, about 1 out of 4 are going to have to go into the ICU. And it is random. I mean, usually we see things worse in people that have risks like high blood pressure, who are overweight, who are older, heart disease, things like that. But sometimes it's young, healthy people. It can be random. So it is really a gamble. Other risks of COVID infection, kind of a misnomer is that, well, in 80% of people, it's mild, so I don't have to worry about it. Mild means that you don't have to go to the hospital, but mild doesn't mean it just goes away really quickly. So what we find is that in a lot of people, you get sick with COVID and it takes a really long time to feel better. So in 15 to 87%, so potentially in a lot of people, they feel tired for 3 months or more after having COVID. 10 to 71% will feel short of breath for 2 to 3 months after. I've heard from people that have been avid runners who can't run for months, or people who can't go up a flight of stairs. And these are young, healthy people. So again, these are the risks if you choose to get immune by getting infected. Many people have a persistent cough for a few months. It takes a long time for the loss of smell or taste to come back if that is something you've lost. People have actually some significant neurologic or mental health problems. There's been post-traumatic stress disorder reported in up to a quarter of people. Problems with memory, kind of that brain fog, problems concentrating for several weeks to months afterward. About a quarter of people feel anxious or depressed after having COVID. And then there's a lot of other symptoms that a smaller percentage of people will report lasting for quite a long time after. So some call this long haulers or long COVID syndrome, but it is much more common than you may realize. Some people don't really want to admit to it. There are people who have been on disability or unable to work because of this. So again, this is a risk of not getting infected, a risk of not getting vaccinated, so a risk of getting infected. This is an extremely busy slide. I know one concern now is with the Johnson & Johnson vaccine, there were some really rare cases of a specific kind of blood clot in the vein in the brain found in the time period following vaccination. And one good thing is this was picked up on the routine vaccine safety monitoring system called VAERS, the Vaccine Adverse Event Reporting System. So after 5 million vaccines were given, these 6 rare incidences were detected and the vaccine was paused so that it could be investigated further. And what they found then on further investigation was that 15 cases had occurred out of about 8 million doses. So that really worked out to be about 1 to 2 cases out of every million doses given. What they found when they really narrowed down on it was that all but one were in women. They were all in women, all but one of them were in women between the ages of 18 and 50. One was in a woman that was in her 60s. So really the bulk of the risk appears to be in women that are 18 to 50 years old. And that rate worked out to be about 7 cases in every million doses given to that age group. It appears to be linked to having low platelets, which we will see sometimes with other medications like heparin given to people. And that seems to be because it triggers your immune system to fight your platelets by accident. In the general population, not people who are vaccinated or anything at all, that type of blood clot in the brain happens to about 14 to 28 per million people with normal platelets. So again, this is less common than this kind of blood clot, just in the general population, but having it with low platelets only happens in about 0.7 to 1.6 per million people in general. So it does seem to be happening more frequently in people that have gotten the Johnson & Johnson vaccine. It's still extremely rare. There's a vaccine that's a similar type of vaccine that's been used in other countries. It's not approved in the United States. We don't use it here. It's been used for a lot longer and in a lot more people than the Johnson & Johnson vaccine, and it has caused some similar issues of blood clots with low platelets. It's actually led to some deaths. The Johnson & Johnson situation, there have been a few deaths resulting from that blood clot as well. So again, that has been really closely investigated. The recommendations now for the Johnson & Johnson is we still use it. However, women who are in that 18 to 50 year age range are offered a choice between Johnson & Johnson and another vaccine. Of note, of the women who've had blood clots, many of them had high blood pressure, obesity. 2 of them were on birth control pills, which is a risk. So just of note there. Now, looking at COVID infection, early in the pandemic, about a quarter to almost a half of patients with COVID that were in the ICU got blood clots. Once they realized that that was a risk, which oftentimes when people are really sick, they get blood clots, they started to realize, hey, we need to put people on blood thinners. So now the risk is about 5 to 10% of people in the ICU, and less than 5% of the rest of the hospitalized patients get blood clots. There's also much lower risks, but still risks of even more serious clots in the arteries, which is a whole different thing, but that can cause heart attacks and strokes, but it still does happen. So again, having COVID is a much higher risk of having blood clots than vaccination with Johnson & Johnson. A recent review of just over 500,000 patients with COVID-19 found that 20 of them had this type of blood clot in the vein in the brain in the 2 weeks after their illness, which the incident with the Johnson & Johnson happened within 2 weeks after vaccination. So that risk then is about 39 per million. So it is about 5 times higher than our 18 to 50-year-old women. They also looked at, this was a British study, they also looked at the risk in those who got the AstraZeneca vaccine, and it was about 5 per million people. So again, still much higher risk with COVID infection. So again, just trying to say, you know, we are definitely watching for issues with any of the vaccines, but still, even with these really rare potential complications, the risk from COVID infection is still much higher. There have been people that have had severe allergic reactions. That's always a risk with any medication, drug, or vaccine. The risk has been about 2 to 5 out of every million people. And usually they are people that have history of anaphylactic reaction or severe allergic reactions. And so far there's not been any deaths reported due to that. They've all been successfully treated like anyone else would be with that. And again, people with COVID infection, about 1 to 2% of them die. So kind of in a summary, so out of the 250 million COVID vaccines that have been given in the United States, there have been 3 deaths resulting from the blood clot in the brain from after the Johnson & Johnson vaccine. So that rate is 0.013 per million vaccines given, or 1.3 people for every 100 million vaccines given. Outside of the United States with the AstraZeneca in England, they've had 32 deaths, which is about 1.5 per million vaccines of that vaccine, which we do not use in the United States. So that's looking at the more severe risks of very specific situations with vaccines. However, out of the 32 million cases of COVID-19 we've had in the US so far, over 500,000 have died. So your overall risk of dying from COVID last year, not just of those who were sick, but of the whole population last year, and it's adjusted by age, was 915 per million people. So we all had a pretty darn high risk of dying last year from COVID. And, you know, comparing that to the risks, other risks, you know, it's pretty substantial. So in this next slide, I tried to put that in a little more perspective. So again, I put those risks from vaccination on the left again. And then again, all of our risks on average based on adjusted by age, from dying from COVID last year was 915 out of every million people. On a yearly basis, our risks of dying in a car crash is 118 per million people. Of dying from antibiotic resistant infections, because a lot of the antibiotics we're prescribed and that we take really without thinking much about it are unnecessary and can cause these awful infections. So risks of dying from that every year is 106 per million. Risk of dying from falling, like off a ladder or down the stairs, is 79 per million. Risk of dying in a fire is 11 per million. And risk of dying in a natural event like a lightning strike or tornado or flood is 5.7 per million. So again, just trying to put it in perspective, we all have different tolerances for risk. I just put it here in a graph so you can kind of get a visual of those risks as well. We all have different tolerances for risk. Someone may not be willing to take 1 out of a million risk and be willing to skydive. So, we all have different tolerances for risks. I don't want to make a judgment for you, but I just want you to try to understand better what these numbers mean. It is really hard to comprehend it sometimes. These numbers are really difficult to put into perspective. But just trying to give you a little visualization here. So just of note, these here are, sorry, catch my words here. These are per million of the entire population in the United States. The ones with asterisks here that are talking about the vaccine, those are per million doses of vaccine given. So the ones for Johnson & Johnson are just per million doses of that vaccine. The severe allergic reactions are per million of all the vaccines that have been given to date. So how does vaccine information or misinformation get spread? So how do we have different things getting spread around? This is a good visual. So misinformation is just incorrect or misleading information. It's not meant to hurt other people, but disinformation is deliberate misinformation. It is designed to deceive or mislead people. Misinformation can be an innocent mistake, but it is still dangerous. Disinformation is dangerous, plus it serves someone else's agenda. So information spreads just like a virus does. It multiplies. So does misinformation and disinformation. When it's exciting, it tends to spread even faster. And unfortunately, it can be deadly if it's keeping people from getting vaccinated or protecting themselves. So if people decide not to spread wrong information, if they check the sources, if they stop that flow, they can help stop the flow of that wrong information. So the World Health Organization and others have used this term infodemic. We're living in an infodemic. Like a pandemic or an epidemic, we're living in an infodemic. So it means we have an overabundance of information. Some of it is accurate and some of it is not. And that occurs during an epidemic like we're facing. And unfortunately, it leads to confusion and ultimately to distrust in governments and in public health response. So it's essentially information overload. You don't know who to trust, you don't know who to believe, and it can unfortunately lead people to make choices that are harmful to their health and their family's health. So this is a nice graphic from the World Health Organization, just tips to help you deal with all this information overload. One is assess your source, who shared it with you and where did they get it from. If it's not someone you recognize, look it up. Go past the headline sometimes, and we catch this a lot. The headline is meant to be enticing, it's meant to be really inflammatory, but when you read the actual article, it really is taken out of context. Look up the author of the comment. They may say that they're a scientist or a doctor, but they may be a discredited individual who's still using their credentials. Check the date. It may be something that was published 10 years ago and really is not applicable to this issue anymore. Look at the supporting evidence. Check your own biases. We all tend to come at things from a different angle, and it's sometimes hard to force ourselves to look at the other side of things. There are some trusted fact-checking sites, and I will share those, that you can also turn to, and they often have already done all this work for you. There are ways that you can help fight this issue. So again, one thing is to not share things that you know are inflammatory or could be false. Learning to evaluate your sources. There's a couple of guides I shared here that are from libraries in different states, but they give a good guide of how to evaluate your sources. The United Nations has made a good program. It's called Take Care Before You Share. And they have some good resources you can share with friends and family or just on social media. So again, people think before they share things because that's how this misinformation gets spread. The World Health Organization has much more information about the infodemic and ways you can work on that. And they also have information on how you can report any misinformation that you do find on popular social media websites. So you can report posts that are false, and oftentimes they are taken down if they are found to be untrue. So this is extremely busy. We will find a way to post this so that you can, link to things. But this top left are several different fact-checking sites. Some of them have hundreds of different myths and things that have come up throughout COVID. They're not political, but they help you to kind of sort through this. And then several other, both general and COVID-based, but mostly just general vaccination resources. Most of them are not governmental, because I know there is some distrust of governmental organizations, and there are a lot that are not governmental. Many of them are actually founded and run by parents, concerned parents. So we tried to pull together a lot of the questions and concerns we get frequently asked so that we can try to address them. We know that, there's always going to be questions and concerns that we just can't adequately address to everyone's comfort level, but we'll do the best we can do. So one that we have heard is, does COVID-19 vaccine affect a woman's fertility or her ability to have a baby? So the answer to this is no, and this has been answered by many other professional organizations. But the vaccine encourages our bodies to create antibodies to a specific protein found on the virus's surface, and this protein is called the spike protein. This teaches our body's immune system to fight the virus that has that specific spike protein on it. So when the whole body enters, the whole virus might enter our body in the future, our immune system recognizes that one protein and fights it. So this myth started after a false report on social media said that the spike protein on the COVID-19 virus was similar to a protein called syncytin-1. Syncytin-1 is involved in the growth and attachment of the placenta during pregnancy. While the spike protein and syncytin-1 share a few similar amino acids, they are not similar enough that the antibodies to the spike protein would fight and attack this protein in the placenta. If it was a real problem, we would expect to see large amounts of infertility issues since the pandemic started nearly a year and a half ago, which we really just have not seen. Also, of note, one of the vaccine manufacturers reported that during Pfizer's vaccine trials, 23 women who were involved in their studies became pregnant. Only one of the 23 pregnancies had a miscarriage, and that individual was actually receiving the placebo, not the vaccine. So just further evidence for this answer. I've already had COVID-19. Do I need the vaccine? Do I need both doses? So the answer to that is yes and yes. The vaccine likely gives you a bigger immune response, which better prepares your body to fight off the COVID-19 virus in the future. We don't know how long a natural infection with COVID-19 provides immunity from the disease. So it is best to still get vaccinated to protect you from getting sick again. There are reports of individuals getting reinfected with the virus after having been sick with it, even if they were very ill with COVID-19 the first time. It is your option if you would like to wait up to 90 days or 3 months after your original infection to get vaccinated, because again, we're relatively sure that for pretty much everyone, you should stay immune for 90 days after your infection. Weren't these vaccines made too fast to be safe? So I had made a video previously, a few months ago, that kind of addressed this. The technology used to develop the new vaccines isn't new. The original research on messenger RNA vaccines really is decades old. This is just really the first mRNA vaccines that have been used widely on the public. The vector vaccine used in the Johnson & Johnson vaccine has also been studied really extensively. I'm going to actually skip ahead. I made some more detailed slides here based on a nice review that I found from Nebraska Medicine. This image here on the left shows the timeline that's usually followed in traditional vaccine development and approval, and then on the bottom, the accelerated path that the COVID vaccines followed, or really they would follow in any pandemic, like they followed with the H1N1 vaccine, or any other pandemic where we were really in an emergency. So researchers had already done a lot of the discovery and preclinical work on other types of coronaviruses, especially when we had the SARS and the MERS outbreaks. They already started researching possible vaccine options, and then those outbreaks ended on their own, so we didn't need to proceed with those. But there's already been a lot of research behind coronavirus vaccines. So researchers knew what types of vaccines and what targets for the virus would work best. So this discovery phase really already existed. So we could skip this 1 to 5 years because it was already done in the past. Plus, a vaccine for the common cold, which coronaviruses are, has always been a dream. And so that has been researched quite a lot in the past. Researchers have been developing mRNA vaccines, which is what is used in the Pfizer and Moderna vaccine, and learning what works and what doesn't work in this type of modality for decades. Really, 1980 was the first time they were able to make an mRNA vaccine. It didn't work because they were just starting it out, but it really has been worked on for decades. The genetic sequence for the virus that causes COVID was available really soon after the pandemic started. That's how we were able to make PCR tests and things like that. So it was really simple for those researchers to find the code that programmed for the spike protein and just kind of plug it into that vaccine technology that they had already discovered and developed. Researchers had also been studying the adenovirus vaccine, which is the type used for Johnson & Johnson for many years. And it is another type of vaccine that you just basically, you need the genetic code so you can plug it in and get to work. The participants for the trials were signed up really quickly using some pre-existing trial databases and registration processes. And because this virus was so common in the community, it was pretty easy to tell if the vaccine was working. Whereas if we were studying a new measles vaccine, it would be harder because we hardly have any measles cases. So that helped with the study. There was a large amount of money invested into this research and development, which usually is not available in vaccine research. It takes a lot of grants and work to try to get this funding. And so that actually made a huge difference in how quickly things could get done because a lot of that red tape was taken away. The buildings and the infrastructure to manufacture and ship the vaccines were being readied and prepared before any vaccines were even available, so that was ready to go and prevent any delays. So that made a huge difference. The process of the FDA review and the re-review of all the data normally takes 6 to 9 months. And I think here in this picture, it says a year, was completed within weeks for the COVID-19 vaccine. This was not because they cut corners, but because they hired extra people. They got more individuals to help review the data. They worked extra hours, they worked weekends. So basically they got it done faster, not cutting corners. And the phases of the trials were shorter than what they usually are, but they still held to the same standards as other clinical trials. They were allowed to be shorter because this is a pandemic and there's a lot at risk if we took too long to get these vaccines out. If the trials were longer, we may have learned more about how long the immunity from the vaccines lasts. If they prevented shedding of the virus in people that didn't know they were infected, or some of these other things we're learning as we go now as the vaccine's being used. But if we waited a year or two to have that information ahead of time, thousands and thousands of more people would have died from COVID or would be struggling with chronic complications from COVID infection. And so we didn't have that luxury. So those trials and those studies are continuing now after it's been approved or authorized. So another question is, should I even bother getting vaccinated since the virus keeps mutating? Yes, the variants that cause COVID-19 does mutate, or the virus does mutate, but it doesn't mutate as fast as some viruses like the flu virus. And so far, the vaccines that we have still appear to work against new variants that are developing. Also, a big thing to remember is that the virus can only mutate if it is dividing and spreading, because the mutations are accidents basically that happens in the genetic code as it replicates. So it has to be replicating to make those mistakes. So the best way to stop mutations and new variants is to stop the virus from spreading. So since a fully vaccinated person is better able to fight off the virus, keep from getting infected, keep from having replicating virus, and stopping the spread, this is going to help stop the development of new mutations and variants. So again, vaccination will help keep you from getting sick, but it will also help stop new variants and mutations from occurring. Why can't I stop wearing my mask and start doing whatever I want after I get vaccinated? Well, that day will come as we get more and more people vaccinated, but for the short term, we know that the vaccines protect you from getting sick, so having symptoms and getting seriously ill. We're pretty sure, and there's more evidence coming out, that the vaccines will keep you from getting infected without having any symptoms and being able to spread the virus to others without knowing it. But again, we're still getting that information to be sure. So until we are sure, and until more people around us are vaccinated and immune, it is important that you wear your mask so that you don't inadvertently spread illness to others, and keep washing your hands, avoiding big crowds, keeping your distance, all those other things we need to do to help prevent the spread of the virus. So will getting the COVID-19 vaccine give me COVID or make me test positive for COVID? So the vaccine for COVID-19 cannot infect you or make you sick with COVID-19. The vaccines we have now instruct your cells to make a protein called the spike protein that is part of the virus. This allows our immune system to learn to recognize the spike proteins on the whole virus if it infects you, and then be able to attack it and kill it. So the vaccines do not contain the whole virus or numerous parts of the virus. So there's no way you can get sick from the vaccine. There's no way you can shed the virus and cause anyone else around you to get sick. And there's no way that you could test positive for infection. You could test positive for blood tests looking for antibodies to the spike protein. So those are tests looking for past infection. Most antibody tests look for numerous different antibodies to different parts of the virus. So they can tell if you have antibodies from the vaccine or from past infection. So if you had an antibody test and you only tested positive for the antibody to the spike protein, that would mean that you are positive because you are vaccinated. If you had antibodies to other parts of the virus, besides just the spike protein, then that would tell them that you were positive because you'd been infected. Will the COVID-19 vaccines change my DNA? Are they some kind of gene therapy? So the vaccines do not change or interact with your DNA in any way. They cannot get into your nucleus of your cell. It's just biologically impossible. So there's currently two types of vaccines. There's the mRNA vaccine and the viral vector vaccine. Both of them deliver instructions in the form of genetic material to our cells to start building protection against the virus. The material never enters the nucleus of our cell, which is where our DNA is kept. So that means the genetic material in the vaccine cannot affect or interact with our DNA in any way. All COVID-19 vaccines work with the body's natural defenses to safely develop immunity to the disease. The vaccines are not gene therapy. Gene therapy is defined as a technique that modifies a person's genes to treat or cure disease. So because they are not modifying someone's genes, they're not gene therapy. So that is a complete misnomer. So I did provide different links that help explain this in different ways and further. I had recorded a previous video and the link is down here. There's also a physician had made some really nice cartoons, which are really neat, that further explain how the vaccines work as well. If people that get vaccinated still can get COVID-19, why should I get vaccinated? No vaccine can be 100% effective in every person. However, studies of the vaccine done before they were authorized found them to be extremely effective in protecting illness from COVID-19. For the mRNA vaccines, they prevented 19 out of 20 COVID-19 illnesses, or 95% effective. The Johnson & Johnson vaccine prevented 3 out of 4 infections and nearly 9 out of 10 severe cases of illness. Real world experience is finding that there are very few cases of breakthrough infection with COVID-19 after vaccination. And studies of the mRNA vaccines have found only around 10% of those that get vaccinated test positive later on, whether or not they have symptoms. So long story short, they are extremely effective, especially if you compare them to things like the flu vaccine. But no vaccine can ever be 100% effective. And that has to do with a lot of different things, not just the vaccine. It also has to do with the person's immune system, who's getting the vaccine, their age, different things like that. So if I get vaccinated for COVID-19 and then I get infected with COVID-19, won't I be sicker because my immune system will go into overdrive? And I'll explain where this myth comes from in a second. But first of all, there have been people who've gotten COVID-19 after being vaccinated, and usually their illness is very mild. So there's no evidence that this is happening at all at this time. As of April 20th, there were over 87 million vaccines, and there were just over 7,000 breakthrough infections reported to the CDC. The CDC is working to get all of these reported to them. So just about half of them were in people over the age of 60, which again, you know, as we age, our immune system is not quite as robust. About 31% of them were found in people that had no symptoms. About 7% of them were hospitalized. And again, of those that were hospitalized, of that 7%, 34% of them were found just on testing, screening testing. They were not symptomatic. 1%, only 88 people died. But again, 13% of those people, or 11 of those people, were not symptomatic. They were just tested on screening on admission. So certainly not evidence that there's huge, overwhelming, severe illness, since, you know, a good chunk of them have no symptoms at all, and only 7% of them ended up in the hospital, when the hospitalization rate is usually a bit higher. So this myth started and has been spread based on a research paper that was written in 2012. And I do have the link here. But it was a study of different vaccines that were being looked at for the SARS virus in 2002. And it was being looked at in mice, kind of in those discovery phases and preclinical phases. So the vaccines that were being looked at were either whole viruses, like the whole SARS virus, or just particles of the virus. And they were studied in, each one was studied in 12 to 13 mice each, so definitely not very big studies. But none of the vaccines that were looked at were anything like we're using right now. And after they were vaccinated, 7 to 8 of the mice that were exposed, 7 to 8 of the vaccinated mice were then exposed to SARS, and then 2 days later, they were euthanized and dissected. And most were found to have high levels of a white blood cell called eosinophils, causing inflammation in the mice lungs. This kind of reaction is called an antibody-dependent enhancement, or ADE, and it has been found to happen during research and development of other vaccines. And there's more information about this at the Children's Hospital of Philadelphia's vaccination website, and I have the link there for you. This is why it is important that vaccines be initially studied on animals so that things like this can be detected, and then those vaccines do not go on for further research and development in humans. So none of these kinds of vaccines have been developed further for human use. So none of this has been found to be an issue in the preclinical studies with the current COVID vaccines. None of this was found to occur in human trials. None of this has been found after being used in millions and millions of people. So again, this is a perfect example of disinformation, when someone is intentionally spreading information that is wrong or misinforming people intentionally. So it's really unfortunate. Why are the vaccines being authorized on an emergency basis, and how is that different from full approval from the FDA? So because of the public health risk of the ongoing pandemic, the Food and Drug Administration is reviewing vaccines along with things like the COVID-19 tests, the treatments, and other things we need urgently, more quickly. The authorized vaccines, the tests, the treatments, and so on have received an emergency use authorization, or EUA, which is typically not as strict as a full license, but it's typically what we use when we're in an emergency like this. So the FDA did add more rigorous requirements for a COVID-19 vaccine EUA than what would normally be required under just a regular EUA. So under an ordinary EUA, regulators must find that the product may be effective and the known and potential benefits outweigh the known and potential risks. For the COVID-19 vaccine EUA, the FDA required that they have at least one well-designed phase 3 clinical trial that demonstrates the vaccine's safety and efficacy in a clear and compelling manner, and wanted to see at least 2 months of follow-up data on half or more of the participants. The FDA also said it expected the vaccine companies to continue to collect data and pursue the full FDA approval. So ordinarily, you just have to find that it probably works and it probably doesn't hurt people. But with the COVID vaccine, they really wanted to see much more specific information that's much more consistent with regular approval. But again, we didn't have time to wait for the full approval because we need to protect people and save lives now. I think I had a side effect from my vaccine. How do I report it? So after you get vaccinated, you can sign up for a program called vSafe, which is a smartphone-based tool that checks in on you after your COVID-19 vaccine. And it asks how you're feeling and different symptoms, side effects, and you can report your problems that you're having through that app. And the CDC does follow that information and has been publishing studies based on it. So the information is at vsafe.cdc.gov. You can also report your side effects or any problems you're having to the provider that administered your vaccine to you, whether it's the pharmacy, the health department, your healthcare provider, and they can report any concerning issues to the vaccine adverse event reporting system. You can also report your side effects yourself to the vaccine adverse event reporting system. You don't have to be a healthcare provider to report things to that system. If you need assistance using VAERS, you can email VAERS, you can call them, and I also put the link on there as to where you can access it and report things yourself. Are the side effects from vaccines that are being reported being hidden from us? So no, they're not. Anyone can access the vaccine adverse event reporting system data. At the easiest place probably to get it is called wonder.cdc.gov/VAERS. Wonder is a spot on the CDC where you can find lots and lots of different kind of data on lots of different topics. One thing to note though, this is raw data. So again, anyone can report any symptom at all about any vaccine. And then contracted individuals that are not governmental, are not CDC, go through and de-identify that data and analyze it to see if there looks to be patterns. And then it's further researched to compare it to, what's the likelihood of this happening in a non-vaccinated person, that kind of thing. So just keep that in mind as you're looking at it, that it is just raw data, but you can look at it at any time and pull data. It is a little bit, I don't want to say it's difficult to search, but it's, it's a big database. So there are a lot of videos that instruct you on how to use it available, but you can do that at any time. So one question that we've heard and another disinformation situation is there a microchip that gets injected into me when I get my COVID-19 vaccine? So this started from a highly circulated video that was edited. It was actually edited and doctored. So someone cut and pasted a video to create this false message. The original message contained a discussion. It was a news interview about an optional radio frequency identification chip that could be part of the labeling on individual dose vaccine packaging. So essentially it was like a really fancy barcode that you could use to identify information about the vaccine itself. It's not used anywhere in the United States. It's just something that a manufacturer in a different country had developed as an option for countries to use. There was never any reference to anything within the injection. You can go to Reuters.com and they have all the information, all the original videos, everything. So you can actually fact this, check this yourself. Just so you're aware, these images, the top here is the injector needed to inject a microchip that is used in animals, and some humans choose to get microchipped for different reasons. That you can unlock your phone that way, you can unlock doors. So it is a bit of an interesting thing to read up on if you're interested, but this is the needle used to do that. The needle below is the needle used to give injections like vaccines. As you can see, there's no way a microchip could fit through a vaccine. And then here below is an image of the actual microchip. So again, that is just deliberate disinformation. Do the vaccines have aborted fetal tissue in them? So some viral vaccines do use one of 3 different cell strains to grow the virus in them. The different cell lines are WI38, PER-C6, or MRC5. Each of these cell lines were started from cells taken from 3 separate fetuses that were aborted decades ago. 2 were from the 1960s and 1 was from the 1980s. They are not all from the United States. One specifically was from, I think, Switzerland or Denmark. They were all aborted by the mother's choice to end her pregnancy. They were not aborted for the sole purpose of making these cell cultures or for making vaccines. The mothers consented to donate the tissue. So these cell lines, you have to kind of know about cell cultures, but the cell cultures have been maintained for all these decades. And no additional fetuses have been used since that time. The Johnson & Johnson vaccine, again, it uses a virus as the host for the message to make the spike protein. The virus host uses the Percy6 cell line to grow the virus. The cells in these cultures are actually called descendant cells because the original fetal tissue no longer exists. These are all like great grandbaby cells over the decades. And so the viruses that are grown in these descendant cells, and then the virus is removed from the cell culture. It grows up into the fluid around the cell culture. It's removed from there and purified. So there are no fetal cells, there's no fetal DNA at all in the final vaccine product. So the Congregation for the Doctrine of the Faith, which is kind of the head office of the Catholic religion, has judged that when ethically irreproachable COVID vaccines are not available, it is morally acceptable to receive a COVID-19 vaccine that has used cells from aborted fetuses in the research and production process. However, if one can choose among equally safe and effective COVID-19 vaccines, the vaccine with the least connection to abortion-derived cell lines should be chosen. Given the worldwide suffering that this pandemic is causing, we affirm again that being vaccinated can be an act of charity that serves the common good. So in other words, if you have, their feeling is if you have a choice, try to choose a vaccine that did not utilize aborted tissue, but otherwise get vaccinated. It is more important to get vaccinated than to not. The majority of other major religions have said the exact same thing, and those statements are available online. So again, it's just important to get vaccinated for the greater good of mankind. So another question is it too expensive for me to get vaccinated? Or, why are you taking my insurance card? You should not get any bill or any cost at all for getting vaccinated. The federal government is providing the vaccines free of charge to everyone living in the United States at this time, regardless of immigration status or health insurance status. The vaccine provider cannot charge you for the vaccine, charge you directly for administration fees, deny you because you don't have insurance coverage, charge you an office visit simply because they're giving you a vaccine, or require any additional services. They can bill your insurance for the administration fee, but if it's not covered, they can't pass the cost on to you. They can see you for an appointment and bill for that appointment and give you a COVID vaccine, but again, they can't make you come in for an appointment just to get a vaccine. Can the vaccines cause me to have autoimmune disorders? So autoimmune diseases occur when your body reacts to itself, so kind of mistakes your own body for a foreign invader like a virus. Some examples include Guillain-Barré syndrome or GBS, multiple sclerosis, rheumatoid arthritis, and type 1 diabetes. Genetic factors seem to put certain people at risk for getting autoimmune diseases, and sometimes infections with bacteria or viruses can be the trigger to start the autoimmune disease. Some germs may have elements that are like our own body's proteins or antigens, and our body makes antibodies that cross-react. Also, as our body is attacking our own tissue that is infected with a virus or a bacteria, it may then develop those autoantibodies, or it just might be that our immune system gets so revved up during an infection that it causes the autoimmunity to switch on. So over time, there have been many times where it has been thought that vaccines could be a risk factor for autoimmunity, and there's been many studies that have examined many different vaccines, and no vaccine to date has consistently been shown to ever cause autoimmune disease. There have been a few studies that have suggested that flu vaccines increase the risk of Guillain-Barré syndrome. a rate of maybe one extra case per every million vaccine given, but natural flu cases, so people that get the flu naturally, we see 17 Guillain-Barré cases for every million people that get infected. The swine flu vaccine that was made in the 1970s, there was some increase in Guillain-Barré syndrome, but since then there's not been that increased risk. Those with a family history of autoimmune disorder, or those that are concerned about autoimmune disorders, should really consider getting vaccinated, because active infections like being sick with COVID-19 do appear to be a real risk for triggering autoimmune diseases. Are we going to have to keep getting vaccines? More recent studies indicate that most people who've had COVID-19 do have a good immune protection for at least 3 months, but likely much longer, at least 8 to 9 months, if not more. Since people who've been vaccinated usually mount an even better immune response, immunity from the COVID-19 vaccines may last several years, but we don't know because we haven't had several years to follow people. A revaccination program may be necessary, especially if we have variants that appear that are different enough from our vaccines that we have now that we need to have a different vaccine to cover them. But as I mentioned earlier, the faster that everyone gets vaccinated, the smaller the chance that a new variant will emerge that threatens our vaccine-induced immunity, because those viruses can only mutate when they multiply, and they can only multiply when they spread from person to person. So the more people we have get vaccinated, the less variants we're going to see. Another question is, I'm young and healthy. Why should I be worried about getting vaccinated? The effects of COVID-19 are very unpredictable. Even though many people with a COVID-19 infection may only have mild illness, some get very, very sick from COVID-19, and they may not have predisposing factors or be elderly. Some may have severe or long-lasting illness. Some die. And again, it may not be someone who has a risk factor. It may be someone who's in their 20s or 30s or 40s. You should receive the vaccine to ensure you are protected from severe illness, from death, from long-term disability. It also helps protect you from spreading it to your family, your friends, and others around you who may be at much higher risk of serious illness and death. Whether you have symptoms or not, getting infected with COVID-19 gives the virus more opportunity to mutate and spread throughout your community. Getting the vaccine helps to stop these risks and stops the pandemic sooner. So do it for yourself, do it for your loved ones, do it for your community. Should I wait and see if it's safe to get the vaccine? So we have a lot of people that are waiting to see before they get vaccinated. As of April 25th, over 250,000 vaccines have been given in the United States. Worldwide, over 1 billion doses have been given. And that's been since December. So we're almost 5 months into this. Side effects and adverse events from vaccines typically develop within days, sometimes within weeks. But given the number of vaccines that have been given, and given that we're 4 months into it, going into 5 months into it, the rarity of any serious side effects and the risks you have from waiting longer, if your wait and see approach has been your approach, you really need to consider getting your vaccine as soon as possible. You've waited long enough, and there's enough evidence now to help you make that decision. So ignore the tables here on this page, that's really busy. So wasn't the vaccine made by the government? I just don't trust that. So a lot of the funding, the plans for distribution, and the resources did come from the government. The vaccine didn't. Private companies and universities worked to develop the research behind the vaccines, make the vaccines. And what the tables illustrate are the voting members of the advisory committees in the FDA and the CDC. They are the ones that make the final recommendations to authorize the vaccines and how we use the vaccines. I put all of their names and their positions here. They are all non-governmental individuals. Most of them hold academic and clinical positions. So again, those members are really the ultimate deciders, the ones that people like myself listen to for advice on how to use vaccines and what vaccines to use. And they are not governmental people. They work on committees for governmental agencies, but they are not governmental. And that's who the governmental agencies have to take advice from. So I just wanted to point that out. There's a lot of intricacies, and it can be really hard to know where all this advice is coming from, but I just wanted to point that out. How can they force me to get vaccinated? So a misconception we hear is that this vaccine is mandatory, the government's requiring it, and the vaccine is not required by the government. And in fact, in the state of Michigan, there really is no required vaccine that's required by our state. You have the right to waive vaccines for yourself and your child, whether it's due to philosophical or religious reasons. Your workplace and other institutions do have the legal ability to require vaccines. And there are many healthcare organizations and other workplaces and colleges that do require several vaccines, like vaccines for common childhood illnesses and annual flu vaccines. Some are starting to require COVID-19 vaccines, unless there is some medical contraindication or reason you can't get it. And, unfortunately, it is getting to that point because we're not seeing enough voluntary uptake to the vaccine to control outbreaks in the pandemic. But again, no government agency is requiring vaccination. So I know this was a very long talk. I just wanted to try to provide as much information as possible, and wanted to give you this information. If you have general questions, the state does have a COVID hotline. The phone number and email is there. To find vaccination near you, you can go to vaccinefinder.org. You can also call the state hotline. But in your areas, I have listed here our different health departments and the counties they cover. You can go to our websites for general information, but also for links to scheduling your vaccine. And if you have specific questions that you can't find online, or you don't have easy access to the internet, our phone numbers are there. We do get quite a lot of phone calls, and so if you do leave a message, please be patient as we work to return those calls. So I thank you for listening today, and I hope we did well to answer the questions that you might have. So have a great day.